So welcome. And we ask that in the screen at the bottom of your screen, there's a chat feature and you can enter your name. We'd love to know where you're watching from here today. And if you represent an organization or you're affiliated with an organization, list that and let us know why you're interested in this particular topic. My name's Christian Beckwith. I'm the director of SHIFT. We're a 501c nonprofit organization based in Jackson, Wyoming, that's dedicated to the advancement of nature as a social determinant of health. And I'd like to thank my colleagues, Dr. Rika Virapongsi, Meredith Davison, and Arian Davis for their help in making this episode possible. I'd also like to thank our sponsors, National Park Service and All Trails. With this webisode series, what we're trying to do is explore the health and nature movement from the perspectives of our various stakeholder groups. So this episode is part of the second chapter, which is focused on public health. The next chapters will feature presentations from the perspectives of conservation, land management, and outdoor recreation. And we've timed them such that they lead up to SHIFT, which we're holding in October. With our various episodes, we've been looking at the why of nature as a public health intervention strategy. We've explored various reasons that exposure to nature is good for you, in particular during the COVID-19 pandemic. But it's not enough to simply talk about the reasons nature is important to our health. We also need to know where and how to access it. So that's why it's just such a great fit to have the National Park Service and All Trails on board. And our parks, as we all know, particularly now, and public lands are some of the greatest places in the country to go outside. We're very much looking forward to the day when the restrictions have been lifted and we're able to visit our national parks once more. And All Trails is the how. So their app features more than 100,000 trails, hand curated by their more than 10 million users. And it lets you find the perfect kid or dog-friendly trail, get driving directions, plot out your routes, and share them with friends and family. So thank you to the National Park Service and All Trails for the work that they do and for making this webinar series possible. And what I'd like to talk about is a little about how we got to this randomized controlled trial project. At last year's SHIFT, we had a workshop on military readiness that examined the therapeutic effects of nature on our wounded and non-wounded active duty service members, including how it could help reduce levels of stress, depression, and burnout, and reduce economic costs to the military healthcare system. The workshop catalyzed a project to study hiking as a mental health intervention for veterans with post-traumatic stress disorder, major depressive disorder. We assumed that such a trial would provide the military with a novel mechanism for a prioritized issue that has broader implications for civilian populations that experience stress, including our first responders, thank you very much, police officers, and our healthcare providers, to whom we are very grateful, particularly now. Today's webinar features a discussion on the study's goals and challenges with its principles. The presentation is being recorded for later distribution via our Slack channel at Shift Nature Health and on our YouTube channel, and you can find out more about the webinar series and the work that we do at our website, shiftjh.org. Following the panel discussion, there will be a Q&A session. So if you have questions for the panelists, we ask that you post them in the Q&A section. You'll find that as well at the bottom of your screen. Please include your title and the organization that you represent in your questions, and we'll try to address as many of them as we can. So jumping right in, I would like to welcome the principals behind this study. They are William Marcin, MD. He's an academic psychiatrist, a mindfulness teacher, and the clinical director and service chief of the Whole Health flagship site at the VA Salt Lake Healthcare System, located in Salt Lake City. He's also a clinical professor of psychiatry at the University of Utah School of Medicine. With us from San Diego is Nick Otis. He's a senior research associate at the Naval Health Center in San Diego, Kumeyaay Land. He's primarily interested in the impact of geography on health, such as the impact of natural environments on psychological outcomes and the nuances of locality on nutritional outcomes. At the Naval Health Research Center, his work with Dr. Kristen Walter focuses on environmental exercise psychology, surf, hike, and other activity-based therapies for those with major depression and PTSD. He also has a research affiliation with the San Diego Veterans Affairs Healthcare System. Also joining us is Dr. Gary Winn. He's an assistant professor and assistant chair in the Department of Psychiatry with the Uniformed Services University. He's also a scientist at the Center for the Study of Traumatic Stress. From 2009 through 2013, Dr. Winn worked as a research psychiatrist in the military psychiatry branch of the Center for Military Psychiatry and Neuroscience at the Walter Reed Army Institute of Research in Silver Springs, Maryland. And in July 2013, Dr. Winn joined the USU Department of Psychiatry. So welcome to all of you. And we just wanted to start out today with a question for Dr. Marcin. And so let me stop the screen so that we can get Dr. Marcin on. Dr. Marcin, we were hoping that you could provide an overview of the trial, including the hypotheses and how you can test.
Sure, thank you. So I want to start off by just saying that this is definitely a pilot study. And by that we mean it's not, we're not developing the study to prove outcomes, but rather to show feasibility of the project. And so we hypothesize that nature exposure can be healing for veterans with post-traumatic stress disorder. And in this particular study, what we want to do is use hiking as a way to expose veterans to nature. And we hypothesize that will help them with their symptoms of PTSD and depressive symptoms as well. And there's some literature to support that. So the way this pilot study will work, we will enroll veterans here at Salt Lake City VA who want to participate in research, do informed consent, all of that stuff, and then randomize them either into just staying in the treatment they're currently in, we call that treatment as usual, or treatment as usual plus this series of hikes that they will go on. And because it's a pilot study, our main outcome is really just showing that we can feasibly do this work, that we can measure outcomes with instruments like PTSD scales, for example. And the ultimate goal then would be to use this pilot data to apply for funding to do a large randomized trial that would really demonstrate effectiveness.
Thank you. And thanks for all the time that you put into this since we started working on it. I think feels like almost a year ago now. And Nick, you've been part of that process as well. And I was hoping that you could talk a little bit about the work you've been doing with Dr. Kristen Walter at the Naval Medical Center on your randomized clinical trial of surf and hike therapy as an intervention for military veterans suffering from major depressive disorder. What have you learned from that trial that's applicable to the development of this study? And how can this study build upon what we already know?
Our randomized control trial is really a two-phase or two-part effort to study the effects of outdoor therapies on psychological outcomes. And kind of in phase one, we evaluated a surf therapy program at the Naval Medical Center San Diego, which is a naval hospital. And service members who are actually active duty attend the program and they surf weekly for 6 weeks. And it's part of their kind of medical treatment. It's considered a medical appointment, which is an important point. We evaluated symptoms of depression, anxiety, PTSD symptoms, and we also looked at positive and negative affect, and we kind of looked at all those things in two ways. So we have what I call these macro assessments, which are kind of the bigger pre and post program assessments. And then we also have these micro assessments, which are before and after each session, which is really important. It's harder to analyze, but it allows for a really fine grain kind of look at the immediate effects of the activities. And I think that's something to take away from that, to apply to work like this. Also, we learned a lot about the covariates and things to control for, adjunctive treatments and things like that. That's also really important for this work. And I'm on a project at the San Diego VA that has some similar design characteristics examining exercise outdoors. And really, the kind of elevator pitch from the first phase of this SURF study was that, you know, it improved all of these outcomes, PTSD, depression symptoms, anxiety symptoms, affect, kind of over the course of the program as a whole. But and it had really big effects on affect, which is also extremely important. But the pattern of change kind of within the sessions kind of actually looks like a wave. So people start, you know, high at the beginning of the session, and at the end of the session, they improve more. They decrease in their symptoms, and then by the next session, they're back up kind of where they were. So it looks like this wave pattern, and that's an important point for, you know, continued benefit of participating in programs like this. And that's also something that we learned that a follow-up data would be good to look at too. And, you know, relatedly, kind of, we've also found in some of our work that people with both PTSD and depression actually improved more than those with just one disorder in you know, this program. And so kind of relatedly, these traditional treatments that are, you know, you're usually very targeted to a specific disorder, right? A traditional treatment for major depressive disorder, say, very targeted to a specific disorder. But what it looks like is, you know, certain types of exercise, in this case, surf therapy, may target kind of multiple symptom types, which addresses a gap in clinical care. For those with multiple disorders, it's also important, given that sometimes, you know, low affect is kind of recalcitrant and kind of sticks around even after successful treatment. So having an intervention that not only decreases negative symptoms, but improves kind of positive ones is really important. And our study had some limitations, like the lack of a true comparison group, which is something that we're, you know, looking to do with this pilot study, reliance on self-report measures, the fact also that surfing is really limited geographically and financially. And Kristen mentioned this randomized control trial, and that's kind of our second phase in this work. And we're now using hiking therapy as our comparison group. And this program's run out of the hospital in a similar manner. And participants now with major depressive disorder are randomized to one condition or the other. It's either going to be surfing or hiking. And they're evaluated by a blinded assessor, and also with self-report measures, a whole host of them. And, you know, the study's going really well. Obviously, right now it's on pause. But we've kind of gleaned some lessons from kind of these 4 years of these 2 phases of the study.
Great. Well, thank you very much. And, you know, when we began our work on this last year, we were very interested in trying to provide some value to the Department of Defense, specifically for active duty service members. And Dr. Winn, I'm curious, can you speak to the importance of a trial like this to the military healthcare system and the need or needs that it might address?
Sure. So first off, while I am active duty, not in my typical uniform, these are my opinions, not official opinions of the Department of Defense. I have to provide that disclaimer. How could it be of value? Well, the military healthcare system, like all healthcare systems, is dealing with a crisis in mental health, and that we don't have enough providers. We don't have enough of just about any kind of resource when it comes to mental health. And one of the things I've been interested in for quite a few years is how do we tap into resources that aren't provider-centric? And this, like other complementary alternative approaches, surfing, which Nick mentioned, are mechanisms that actually offload the burden of mental health requirements onto something that can essentially take as much as you can give, right? I mean, nature hikes, people can, it would really be hard to overload national parks in the United States with people taking too many hikes or surfing too much, or there's just an abundance of natural resources in our current configuration in society to tap into as a mechanism to treat the low-level symptomatic group of folks who have major depressive disorder, and maybe they never see us. How great would that be, to be quite honest, that they are completely taken care of by some mechanism like this. And then you move into those who are mid-level sufferers. Maybe you're doing some combination of brief psychotherapy or low-dose meds and kind of intervention like this. And then even for the high-level sufferers, you could be using this as an augmentation on top of psychotherapy and medication and some other intervention. So it actually can play a role across a number of potential intervention strategies to help decrease the current existent burden on the system itself. So, and it's good for people.
Yes. And I see we are getting some questions from participants. So do feel free to use the Q&A section at the bottom of your screen if you have any questions for the panelists, and we'll get to them as soon as we finished up a few preliminary questions here. Dr. Marcin, you've conducted studies on the ability of therapeutic sailing to positively impact anxiety, psychological flexibility, and treatment outcomes. How have your findings influenced your thinking on this proposed study, and why are we focusing on hiking instead of another form of outdoor recreation?
Yeah, so here in Salt Lake City with a number of colleagues, we did several pilot studies of therapeutic sailing, or you could just call it recreational sailing. We did sailing alone, and then sailing plus a mindfulness training. And we were quite impressed with the results. Again, it's pilot work, but we were impressed with the results, and the veterans loved it. And I think that's sort of another piece of this, that while we're talking about this study that we're planning as an intervention, it's also a way for people to live a healthy, more active lifestyle and enjoy their lives more. So that side of it, I think, is really important. Also, so part of what we got from the sailing studies was that, hey, we want to keep doing this and try other kinds of outdoor exposure, nature exposure interventions. The thing about sailing is it is a limited resource. You have to have the boats, you have to have experienced people who can be skippers on the boats. So it's quite costly. The really good thing about sailing is that it's very much an adaptive sport, so the people with challenges with ambulation or various other physical disabilities can typically participate pretty easily. The disadvantage, though, is what I mentioned earlier, that it's costly, it's equipment intense, it's personnel intense. So we're really interested in doing something like hiking, which most people can do, and which, not only may it be therapeutic for them, it may be an activity that they want to continue on their own after the end of the study or the intervention.
Yeah, thanks you. And that was one of the key considerations that we discussed as we evolved the study. So just the accessibility and ensuring that we're doing something that most people are able to do, which is really important. And in some of our earlier iterations of the project, we explored focusing the trial on something that's a priority for Department of Defense. So we were looking at the efficacy of hike therapy as a mental health intervention that could help address the prevalence of suicide among veterans. And Dr. Winn, you had some really good counsel on that. I'm wondering if you can talk about why we didn't go there.
It's a very big topic. Suicide is incredibly important. I deal with suicide on a regular basis, both in my research work and as a clinician taking care of service members, dependents, and retirees who access the healthcare through the military healthcare system. It's a very, very complicated topic. The other thing is it's actually relatively rare. So studying it is very complicated in terms of getting the size of groups to make actual assessments of impact on suicidality, and you have to parse it out into where you're talking about suicidal ideation, the thoughts around suicide, suicide attempts, the actual attempts around suicide, and then those who complete. And those actually, from our research, are different categories of people with different risk factors, with different interventions. So it gets super complicated and requires very large numbers that would far outpace the kind of thing we're talking about here, which is, can we take generalized distress, which is really what we're talking about, but just distress associated with PTSD, the distress associated with major depressive disorder, and can we bring it down a notch? We are actually not talking about curing PTSD or curing major depressive disorder. We're talking about symptomatic management through this kind of intervention. And that's very different than what you're talking about in terms of intervening when it comes to suicide. I'm in a program that's worth tens of millions of dollars, army-wide size things, and we still at times struggle to have the size of numbers to really properly evaluate interventions. So for this kind of study, for this kind of thing, we're going to set aside suicide. There's probably likely subsequent benefit, because as you decrease generalized distress within the context of PTSD or major depressive disorder, you're likely to get a decrease in the potential for suicide. But we don't know that for sure, and this study is not powered, capable, funded, able in any way to really address suicide properly.
Yeah, thank you very much. Nick, I want to go back to your experiences with the Naval Health Center's randomized clinical trial and just ask what you foresee as some of the challenges to executing this study.
Yeah, so first, there are likely specific population challenges that Dr. Marcin might be able to weigh in on for this particular study, given that it's a population that he works with each day. But that aside, attendance, as I mentioned earlier, in our work at the Naval Medical Center, these sessions are considered a medical appointment, which I think helps attendance, helps accountability, and things like that. So kind of this juxtaposition of a program versus kind of a medical appointment, maybe something that we consider in terms of a challenge. And measurement specific wise, there are some validated kind of short measures for PTSD, but they're in the beginning stages of they've only been studied just a little bit. It's kind of undetermined whether or not they're sensitive enough to change to use them in a session by session basis, right? If you go for a hike therapy session, is that going to impact re-experiencing or flashbacks and things like that in that 3 or 4 hour window? Are we going to be able to, is it a measure that's going to be able to measure the change that is actually occurring? Is it sensitive enough to change for the particular activity? I'm not sure. But there are, of course, shorter measures of other things like depression and things like that do really well. But as far as measuring PTSD goes, that might be kind of a challenge for such a short time frame. And then self-report is always has limitations. People's interpretation of questions or kind of things of that nature. So that is a limitation, a challenge. And then the last thing is controlling for different covariates, because different things that maybe contribute to some of the outcomes we're seeing. And one way to kind of mitigate that, I think, is these little kind of micro assessments. The pre-post of every session really provides this kind of fine-grained detail, but kind of overall for the program and for follow-up data too, being able to control for those things and capture all of them in order to control for them can be challenging too.
Yeah, thank you so much. Dr. Winn, I've got another question that really gets to the heart of what we were trying to do with last year's workshop. And what I'd like to know is what sort of evidence would the Department of Defense need in order to invest in nature-rich interventions as a population wellness strategy?
All right, so I'll give the quick disclaimer again that my opinion here does not represent very specifically on this one, because I don't want anyone to get the idea that I'm telling you how to. But in general, in concept, you know, when I spent quite a few years working on the funding side of things, we funded tons of projects across PTSD. I ran the PTSD portfolio for the Department of Defense for a while. We wanted evidence, right? You know, we wanted good, solid, well done, scientific, classic approach evidence where you took well-validated measures that were proven in the psychology, social work, sociology, psychiatry world, and you use those in a well-structured approach. And you also had good, what we call manualization, right? And manualization is one of those things that's incredibly important, but I think often overlooked. And that is, how do you tell me that you did these specific behaviors on these specific days in this specific order, such that I can then hand that manual to someone else and have a pretty solid expectation that when they implement them, the person who is undergoing the intervention will experience roughly the same thing. Now, whether it rains on a certain day or sunny on a certain day, there are things you can't control, but timing, pacing, what kinds of things you did, are you doing a mindfulness thing before, are you doing a yoga thing after, are you doing all of those pieces? And I would look at programs across and they'd say, hey, we'd like to be funded for this project. And like, show me your manual that tells me you have a plan for how you're going to do things on session 1, session 2, session 3. And they would kind of be like, well, if they want to do yoga beforehand, that's cool. I'm like, that's not how it works in science. They need to all do it or not do it. You know, you need to have a plan. And that kind of basic science would be the thing that then steps into a larger project that potentially gets funded. The other thing that a lot of folks do is, I think Nick mentioned, is that wave of, you know, you get a little bit better after the intervention, and then by the time you come back a couple of weeks later, you're back to your symptom level that you had before. We want to see that a month or two later, that if you do 3 or 4 sessions, so that you know, you do the intervention and your symptoms are down and it gets up and down, but over time that wave is flattening and you're actually having sustainment of reduction in symptoms, but that sustainment and reduction in symptoms lasts longer than a couple weeks, because we call it the vacation effect. You take anyone out of their stressful environment and you send them to wherever to hang out on the beach and do nothing but drink Mai Tais and chill out for a couple weeks. Most people feel better from that, but that doesn't sustain. And as an enterprise, we are not interested in investing in things that give people a week or 2 of benefit. We are interested in investing in things that will give some kind of sustained benefit or has a plan for continued intervention, whether that be medication where they take it every day, or for this thing, the hike therapy, that there was a plan of, you know, you're going to do your sessions, and then here's a follow-up plan that says you do it at this time, this time, this time, every week, you engage every 2 days, whatever it is, so that we know that when we invest, we know we're going to get a sustained benefit. It's probably the biggest problem is that, you know, yay, people feel better for a couple of weeks, not what I need. I need solutions that sustain over time.
Yeah,
and that can port from thing to thing, right? So I can send it via an email to Alaska, to Fairbanks, to Fort Wainwright, to Fort Riley, Kansas, to wherever in the world, and know that as that provider reads that sheet, that manual, that when they implement it, it'll be roughly the same thing that was tested.
Thank you. We've got just a few more questions, and then we do want to jump into some questions that we're getting from participants. So if you do have some, put them in the Q&A section at the bottom of your screen. Dr. Marcin, talk to us about how this study will be funded, and in particular, what else would we need in order to help execute it?
So the short answer is it's not funded. This is as I mentioned earlier, it's a pilot study, and our goal is to then use these results to apply for a large grant, like Dr. Winn was discussing from DOD, VA, or NIH. We're able to do it because in Salt Lake, as you mentioned in the intro, we are a whole health flagship site with our focus being to change healthcare within the VA to something that's much more focused on health promotion, disease prevention, and using complementary and integrative healthcare. And as part of that, our mission is to develop new interventions and test them. And this being an example of that. So we're essentially doing the study with staff that we have on board, or money that we have. What we need, I think, mostly would be something to help with incentivizing veterans to participate. One of the challenges in this kind of research, I think Nick alluded to, is that there's often a high attrition rate of people who are enrolled, or challenges getting the people enrolled or completing all the measures. So oftentimes in research, we use incentives like a gift card or a piece of equipment to encourage veterans or anyone in a study to complete the study in return for getting that gift item. So in an unfunded study like this, if we had some of those sorts of incentive items, I think that would help us significantly.
Mm-hmm. And our sponsor, All Trails, has offered to provide pro accounts to any of the participants in the study. Is that the sort of incentive that would help with participation?
Absolutely, yes, and we're very appreciative of that.
Thank you. So, we're having this conversation in the midst of the pandemic, and we've talked in some of our meetings about how the COVID-19 will affect the development of this study and how the results might be applicable to civilian populations in a post-pandemic world. And Dr. Winn, you had some really good observations about that. I wonder if you'll share them with us.
Sure, happy to. Anyone who's been reading on the topic will see increasing discussions around the coming mental health crisis associated with the burden that our frontline workers, from healthcare professionals to required retail, such as grocery store, warehouse workers, the people that make our society continue to function while a huge number of us are on lockdown or at home, are facing the possibility of being infected. There's fear, there's just a potential for getting sick. Those who do get sick, there's increasing question about whether there's essentially a traumatic experience from that. There's going to be a big mental health burden, a wave, if you will, that many people think is coming once this settles down, once we're through this experience. And we are going to need more resources than we currently have. And you cannot produce more mental health clinicians of any sort with any speed, right? It takes years to produce the psychologists, social workers, psychiatrists, years of training. Even your most basic counselors take a couple of years of work to really get prepared to deal with this kind of thing. We're going to need options. We're going to need ways to take care of folks and give them alternatives. Given that one of the things about the quarantine and the experience around COVID is isolation, is staying indoors, is having masks on, is feeling disconnected, there is a concept that I've been thinking about, we've talked about on a couple of our calls, that nature may be a very attractive way to address at least a portion of this mental health wave that's coming. The other thing is, you can do a good hike and social distance at the same time. There's nothing to say that you can't keep all of the right kind of protections about yourself. I was out on a walk the other day, and people were stepping a few feet off the trail to let the person pass and have your 6 feet of distance. So people are already kind of figuring it out. And anything we can do to take the relatively mentally healthy and keep them out of the system by being healthy, not saying that they shouldn't if they don't need it. The more we can keep them away from the system, the better off we are. because we will need every resource to address the very urgent need that is likely coming.
Thank you so much. We want to jump into some of the questions from participants now. I'm seeing a number of good ones from Kathy Wolf, I believe with the University of Washington. One of them is regarding the wave pattern that was brought up at the beginning of this conversation. She asked, what would that suggest a treatment regime of repeated nature exposures and duration? Nick,
Something that
say that.
Have, you know, concluded from some of the work that we've been doing. And I think that's the short answer, is that repeated exposure is necessary. Yeah.
I think to jump on top of it too, I think that's I call it the dosing question, right? So how many times, and I have this about a number of different projects I've consulted on. There's one group that did fly fishing, a group that did kayaking, skiing, is how many times do you have to do it? How often do you have to do it to get that effect so that the waveform isn't rising all the way back up to pre-intervention levels, and that you've muted the curve and you've flattened it down at a lower level of symptoms, and that you sustain that. So there's likely a higher level of dosing up front, but then there's probably a repetition of intervention. So let's take hiking, you know, we're doing it, I think 3 times over 3 weeks, if I remember correctly. Dr. Marcin probably knows it in more detail than I do. You know, is weekly enough? Are we going to need to do it a couple times a week? Are we going to need to do it a couple times weekly for a couple of months, and then they have to do it every 2 weeks? There's a ton of these sort of follow-on questions about what's the dosing that not only decreases symptoms, but maintains that decrement in symptoms over time.
Mm-hmm. And Kathy has a good follow-up question as well about these activities that we're talking about that often are, they require a level of affluence to achieve in sailing therapy or you know, you were talking about surfing therapy, for example. So she points out decades of research show mental health benefits of nearby nature encounters. She asks, could community gardens and walks in a park or green streetscapes near home, might these be used as control treatments as well?
Yeah, I'm happy to comment real quick on that too. Is I think one of the reasons I'm such a big fan of this project is I will call it foundational, right? Walking. But when you boil it down to, we're talking about walking. We're talking about walking in nature, and I get that. And I'm not trying to diminish the study in any way and the importance of being out near nature. But I think one of the foundational questions is walking in some way, you know, maybe a community garden too, is that interaction there a viable pathway because of the lack of resources required to participate in it? Because I have the same question. I have the same question on a couple of those studies I consulted on. Yeah, are we expecting everyone to go buy fly fishing rods and waders and, you know, take a trip out to a river, or, you know, get a ski pass for the year, or buy a kayak, or all of these things that are pretty expensive, time and geography dependent? Walking is not, and that's one of the reasons I'm really interested in this stuff.
Mm-hmm. Yeah, thank you. We've got another one from Dave Sheehan. Have you identified particular characteristics of the physical activity used for intervention that are beneficial or necessary for this type of intervention? Dr. Marcin, do you have a response to that?
I guess the short answer is no. Part of what we don't know, I think this is what was being alluded to earlier, is that, you know, there probably is some therapeutic benefit just from the walking. I mean, there's tons of literature around the value of exercise for mood. We are particularly interested in the nature exposure piece of it. Most likely that the two, the physical activity and the nature exposure, work synergistically to help people feel better. But we're not really looking specifically at the physical activity in this particular project.
I will also add that I think that, there are a lot of theories. I think there was another question too, kind of about this, but there are a lot of different theories as to why, exercise and why exercise in a natural environment or natural environments themselves, mechanistically, why they, what they do. And kind of in terms of physical activity or hiking, I think one of the ways that you can at least control for such things is, to use something like the Borg measured perceived exertion scale, which kind of accounts for people's levels of exertion across different activities. So, in our study, surfing and hiking, but elsewhere it can be used, on its own to kind of control for that effect of physical activity, at least how someone perceives it, because we know that there are differences in psychological outcomes based on perceived intensity and things like that too. So I think there are quite a number of social interaction, or a number of, self-efficacy is one. I think there was a question about that. That is a big kind of component that's hypothesized for exercise, the ability to set a goal and achieve that. And so I don't think in these studies we'll be able to tease that out too much, especially considering this is a pilot study, but there are certainly ways that we can try and tap into, different kind of measures.
Mm-hmm.
To jump in real quick, I think if this were a world with unlimited resources for research, I'd probably be advocating for a repetition of this with a control that is walking on a treadmill in a relatively sterile environment to see, and make sure that they get roughly the same exertional capacity with roughly the same amounts of heart rate elevation, all things you could control with and monitor using actigraphy or EKG, et cetera. So do that and then compare it and see if there is that additional benefit. And then you would also then want to do it comparing walking in an urban environment, suburban trails, rural area, forest. I mean, there's a ton of these sort of follow-on questions about really teasing out microscopically the differential variation. I think in general, though, the belief we all have is that nature, real get out there in the woods nature, is probably substantially different to be synergistically beneficial on top of the walking.
Mm-hmm. And we've got some great colleagues in Dr. David Strayer there with the Applied Cognition Lab at the University of Utah who's doing work on the differences between exposure in urban settings and natural settings. So there is this growing body of evidence that can support this study as we move it along. We've got another question from a friend from the nursing community, Susan Allison Dean, regarding whether you see a benefit to having a therapeutic leader in these interactions versus the participants engaging with nature on their own.
So this is another possible synergistic effect, having a leader such as a recreational therapist who could help process the experience with the veterans, or a leader who might provide a mindfulness-based training to go along with the nature exposure. So the answer is yes. I would think that adding some of these enhancements would likely to be synergistic again and lead to increased benefit, at least for some people. We're trying in this particular case, though, to really look more specifically at the nature exposure piece. But again, I think, as was said earlier, there are many follow-on studies that could be done. And my particular interest is actually combining this nature exposure with mindfulness training. And so that's something that I think, we would be doing in the future.
I think additionally too, having a leader of some sort, or a recreational therapist, et cetera, is important for kind of just programmatically, especially, people that might not be familiar with a certain activity or with guidance, kind of connecting them with local resources, things like that. I think there's a programmatic element to a leader too that I think there's another question about this in the comment section here, is that if you can utilize that to get people to do this preventatively or to do this kind of on their own, I think that a potential, recreational therapist or leader in that regard is really important.
I also want to jump in and say that I think it's important for the concept of manualization of how do you ensure that it is done the same way every time. And when you're talking about programmatics or additional funding, et cetera, when someone who's going to spend money on this looks at it, they're probably going to want to see that you can do it the same every time. And that's all part of the manual. What is the leader doing? What are they facilitating? How are they coordinating? And how are they controlling as much as they can the experience for the individual, so that each of these interventions, hike 1, hike 2, hike 3, hike 4, however it's laid out, mindfulness before, all of these factors are laid out in essentially a spreadsheet or a table saying, here's what we're doing and how, and the leader knows to do it. Some of the ones I've worked with actually down to the script. So what the leader says is actually specified on some of the interventions. So you can get super detailed with it. Doesn't have to be that detailed, but I think a leader is absolutely required if you're going to do anything that's going to be looked at for funding or for programmatics or for involving it. Otherwise, it's just hiking and, hey, go have fun, guys. We totally support you. That's just the funding side, the big Army, big military, even probably the VA side from my interactions with them are going to want to see that leader.
Mm-hmm. And so we have a point here from Dr. Donald Schell. He's the Director of Disease Prevention, Disease Management, and Population Health Policy and Oversight with Defense Health Headquarters, and was part of the workshop that we developed at SHIFT last year. He says, question for the doctors, are prescriptions for nature exposure coded and documented in patients' treatment protocols or charts? If already done or possible, utilizing ICD-10 codes may be a feasible mechanism to facilitate determining the impact of the nature exposure to clinical outcomes.
I'm totally unaware of whether that's happening. And hello to Dr. Schell, not that far away from me here. I don't think so. I honestly think that most of the time, my personal experience and the experience of my friends and colleagues who are psychiatrists in the military, those who are interested in complementary and integrative health, will make comments and coordinate around whatever local resources there are. There are a number of them here in DC programs. There's an equestrian program. There's a hiking. There's actually, it's from a German Volk something. It's called Walking About. So there's a group that has a German origin. They go on walks and they do it for vets. So there's a number of those, and I'm aware of those, and I will sometimes suggest those to my patients, and I write it in the note, but I've never coded it, and I'm unaware of any ICD-10 code for recommending nature, but ICD-10 is huge, so it might be in there. Volksmarch, someone said it. Thank you. Rob Smith, thank you. Volksmarch. That's it.
One of the projects we embarked on after the last shift was an effort to document the various nature-rich interventions that exist for veterans with various conditions. And we've identified, we did a fairly decent look at around 35. We identified another 150 or so, and then ran out of funding, of course. But I'm curious, you know, for all these various interventions that are already out there for veterans, if there were one or two things that you could tell them to focus on with their interventions that would help with the establishment of best practices in this space, what might those be?
In the exercise research, there are some kind of bigger gaps that need to be addressed, and they also apply here, considering that a lot of this nature exposure work involves exercise. And of course, there's replicability, which is something that we've talked about. There is also the need to use validated measures, and especially those, the more rigorous, the better, right? So blinded assessors when possible and things like that. But using validated measures, especially ones that map onto diagnostic criteria, is important. What else? Follow-up data is really important. Those are at least 3 things that I can think of that can be applied to other interventions of this nature in general.
We've only got a few minutes left, and we've got more questions than time. I did want to flag one from Jim Ritterhoff with Force Blue. He was one of our Shift Award official selections a couple of years ago. And he asked, where, if at all, does the idea of team fit into these studies? Surf and hiking are solitary pursuits unless conducted in groups. Just curious about how getting the band back together factors into the equation from a veteran's perspective.
Well, I think that is very important, and we often discover doing various kinds of group work with veterans that the camaraderie, spending time with fellow veterans is therapeutic. So in the hiking study, we will be taking people out in groups. So again, it's probably another factor that will work synergistically with the nature exposure. Ultimately though, hopefully people would hike on their own after the end of the intervention, but that could happen in a self-formed group as well. I don't know if others have thoughts about that.
Yeah, I think, something that we've done in previous studies is controlling for the effective cohort, which is important, but I think the takeaway is that social interaction has been linked with mental health, and I think it's definitely an important consideration. Also, kind of this mission, this goal, again, the fact that efficacy, or the fact that it's a goal setting and you can do something, is also hypothesized to be a really important part of exercise too.
The issue around team that we've struggled with is as the other 2 have mentioned, but how would you integrate that into an intervention, right? Unfortunately, people primarily come to healthcare solitarily. Now, if we're talking about prevention within units within the military or peer groups within the VA, I know there are a whole series of things around peer-to-peer, et cetera. There are teams that existed, but we're kind of talking more on the healthcare intervention side at this point. And in that case, it's rare to have a team that you would then bring together somehow to do an intervention, which is why we often take the leader approach.
Thank you. And we've got a good one. We've got probably time for 1 or 2 more questions here from Dr. Kramer at Northeastern. So Dr. Kramer was responsible in 1997 for the paper in Nature magazine that established the correlation between physical activity and cognitive and brain health. And he asks, I wonder if the literature on physical activity and exercise interventions might provide some guidance, for the study of nature exposure on mental health, cognition, and brain health. The PA/exercise literature has been pursued for several decades and has explored a number of issues being discussed in this webinar.
Yes, very much so. Bioactivation, I think, is an underpinning to this whole thing. Teasing it out gets a little bit more complicated, I think, has been mentioned, but the literature you refer is, I have incorporated that into numerous publications I've worked on and research efforts. That I think it's foundational.
Mm-hmm. Okay. And Bill, there might be an opportunity to connect with Dr. Strayer there at the University of Utah, who works closely with Dr. Kramer, and see if there's opportunity for collaboration. Yeah. So we'll hit one other question, and then unfortunately we'll move the conversation from the webinar to our Slack channel, where we encourage you to continue the great dialogue that's going on here. And this is from Jen Greene, who is interested in your survey methods. What kinds of questions do you ask? Do you survey veterans every trip? How do you evaluate your findings?
I think that's something that we're still working out, but I think Bill will also be able to add to the design. Hopefully, is a pre-post, 1-month follow-up with some micro assessments in there before and after each session, measuring symptoms of depression with, whether it's a PHQ-8 or something, anxiety. We had enjoyment too, I think, but making sure we have kind of a mix of things and a mix of measurement periods as well.
Yes, that's correct. We're still discussing, but tentatively we're planning to look at physical activity enjoyment scale, then several symptom scales around depression, PTSD, affect, psychological flexibility, and quality of life. So these are all validated measures that we'll be using.
Gentlemen, thank you so much for your time today and for all your work that you've put into this project. It's been a work in progress for quite some time, and Nick and Bill in particular, you've really contributed an awful lot of your free time to this project. So thank you very much. Dr. Winn, thank you for joining us from the East Coast. And let's see, I do want to, in thanking you all, just say goodbye, stay healthy, and keep your chin up through all of this. And to those of us who are joining us, we encourage you to stay connected with this project. You can find out more about it on our website. That's www.shift, like Jackson Hole.org. It's under the projects section. So it's nature exposure for veterans. We'll also be sharing this on YouTube. So we record these and post them. You can find that on our website as well. For the research community, we include the slide deck on Figshare. We also encourage you to join us on Slack at Shift Nature Health. Next webinar is coming up next week. We're looking at nature as a social determinant of health. This is with Peter Angood. Dr. Angood is president and CEO of the American Association for Physician Leadership, and Dr. Lisa Fitzpatrick, who's the founder of Grapevine Health. She's a professional lecturer at the George Washington University Milken Institute School of Public Health, member of the Aspen Institute Global Leadership Network. So next Tuesday, 10 a.m. Mountain Time, we'll be putting out more information about that webinar as well. Announcements, we are extending the deadlines for the 2020 Shift Awards to June 15th. You can contact Arian Davis about that. Same for the Emerging Leaders Program. You can contact Dr. Morgan Green regarding the ELP, and the research abstracts for the poster session that we'll be having at Shift. You can give me a shout about that. We're extending that deadline to June 15th as well. So thank you very much for joining us. My name is Christian Beckwith. I'm the director of Shift. It's an honor to be working on the nature and medicine movement with so many folks like our colleagues here today. And with your help, we will advance and promote the health benefits of time outside. Thank you.